Hello.
Hi.
Hi. Hey, Dr. Brandy White.
Hello.
Oh, is that your doggy?
Sorry about that.
Sounds like a vicious dog.
It's
So
How's everybody doing today?
All right.
Sound tired.
yes, Dr. White, that was not very convincing.
All
Sorry.
right.
We had summer camp today. So we had 14 kids show up for summer camp. So
Oh my
worn out.
goodness.
Understood.
Everything was outside and it was hot.
Yes, I was going to say on the
Oh
hot
my.
the week, maybe for the summer.
Outside today. Yeah, today it's extremely hot.
Yeah. So, hey, Casey.
Hi.
You look very good. I know you.
You gotta fake it till you make it.
No, well, you're doing a fine job.
Yeah.
Thank
You
you.
take care of yourself, Casey.
I will.
Yeah. So I guess, are we ready to start?
Yeah, I don't see Andrea.
Yeah.
Is she here?
I haven't seen her, but I need to expand.
Hey guys, yeah, Andrea should be logging on here in just a second.
Okay.
All right. So should we start? It's at the time, right?
Yes. Takeda, you have the statement
do.
available. If not,
yeah.
I do.
I have it. I'm ready
Okay.
to go.
Fantastic.
Okay, so I'm going to read the COVID statement to start our meeting off. Due to the COVID-19 pandemic, state of emergency, and Governor Beshear's executive orders regarding social distancing, this meeting is being held via teleconference pursuant to Senate Bill 150, as signed by the governor on March 30th, 2020, and Attorney General Opinion 20-05, and in accordance with KRS 61.826, because it is not feasible to offer a primary physical location for this meeting. So thank you all and welcome. Great to see everyone's fine faces before us. And in an effort, and I don't know, Quinn, you can direct me on this. Do we have to do any kind of official roll call for the meeting? Mostly everybody was on the last meeting. I think we have Dr. Gillum, maybe even Mr. Moses. And I'm forgive me because I may leave someone out. Yes, Quinn.
I don't believe you've got to do a roll call. No, I think it just needs to be noted in the minutes who's here and who's not. And I think Andrea has just joined us. Actually, I don't see her, but I think that's her that called in. Andrea, is that you?
She's on mute, so
yeah.
She's
let me get a hold of her. I'm actually not going to be staying with you guys today, but she should be here in just a second. Let me try and get a hold.
So we're going to proceed because time we have a limited time here. So hopefully she can join us very soon. So welcome everybody. I'm Takia Talbert, one of the vice chairs, and so fabulous to see all of you yet again. And so in honor of time, what we're not going to do is all the individuals who were here the last time, we're not going to have you state your names again, but we will have, and forgive me because it's I'm trying to catch everybody as they're joining or how it's changing on the view here, but we will have an opportunity, of course, for those new individuals, because I think Dr. Gillum was not with us the last time, nor Mr. Moses, perhaps. So do you want to just state your name to the team and your affiliation? So Dr. Gillum? You're muted. You're muted.
Can you hear me now?
Yes.
I hear you.
Everybody's like, anyway, sorry about that. But Dr. J. Gilliam, affiliated with Baptist Health and board certified internal medicine and pediatrics.
Excellent.
Happy to meet you.
Yes. Welcome. Welcome.
And this is Mark Johnson. I'm on John Moses's phone.
Okay. Yeah.
But Mark Johnson. I'm with the Kentucky Department for Public Health.
Hey,
Great.
Mark.
Great
Hello.
to see you, Mark, and welcome to the team.
Thank you.
Mark, are you at the health department?
I am right now.
Mark.
Okay,
I'm
great.
technology. I'm challenged that way. Hey there, everybody.
Hey.
Okay, so hopefully I'm not missing anyone. So please speak up if I am, and I apologize if I did. Okay, great to have you. So everybody has the agenda, correct? It's been attached to our meeting invitation. So we've done our COVID station, welcome and introductions, and now we would like to move on to the approval of our last minute meeting minutes. And have you had an opportunity to review those? They were very short.
So moved.
Okay, great. So Kathy Pullman, so that was a first motion that we accept the minutes as sent out to us by the wonderful Andrea. Is there a second from the body?
Second,
A second.
Okay, and who did that?
Timothy.
Okay, Timothy, great. Thank you very much. So if the body, all those approved by denoting by aye.
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 Oh,
Aye.
excellent.
Aye.
Opposed, nay? Okay, I think we have everybody. Thank you, Mike. All right, so very well. So that's probably the most formal part of the meeting, right? So getting all that stuff out of the way. And before I turn this over to my colleague, Dr. Williams, I wanted to just make you all aware of a few dates that are upcoming. And that would include a meeting with the mayor or her representative tomorrow with the co-chairs and vice chairs to do an update, okay, just so that you all are aware, and that's going to be from 11 to noon. There's also a tentative date set up for a town hall meeting for public feedback, which will be on the 28th of this month of July, and that's for 6:30 to 8 p.m. And that is kind of, I think, still in motion. So that is tentatively on the agenda. And then August 4th, we will have a special meeting with the vice chairs, co-chairs with the urban county government to give them an update on the commission's work. Okay. So just so you all are familiar with those dates and those upcoming events. And are there any questions about that? Comments? Yes.
Here, I was wondering, can we access those updates? Are those available for us to watch, do you know, or?
Well, I would think so, but I would have to leave that to Andrea to comment on, and hopefully she'll be joining us soon.
Okay.
But my understanding is such that that is the case, Kathy, and we would need to confirm that, okay, before I commit to that. Great question, though.
I have a question, and I'm not sure where on the agenda would be appropriate to raise it. It's sort of a general question about the work of the committee.
Okay.
So I think we all got an email from Commissioner Ford saying
Yes.
that the mayor was open to more time.
Yes.
Is it something that we're going to avail ourselves of?
Well, because if you read the same email I read, and I believe we received the same communication, that to me was somewhat vague. And to that end, I believe we should stay on course. I know people, and Dr. White, people may feel very strongly about that, but I believe that we should continue on our course. And I talked this over with my co-chair here. I'm not deciding or stating that in solitude, but because that was so vague and it really didn't give us any new time frame lines, I believe that we should continue on the course that we're on with the intent to hopefully do what we're going to do in the meetings that we've already established. And if we find by our next meeting or even the last meeting that we're unable to have a final product for us to prepare to give to the mayor and the co-chairs first and meet the August 30th deadline, then I think we rethink that at that point. I mean, is that fair to the team? Because I didn't feel that the email was very directive in that now we have until September, or it just said that if we identified the need to have more time, then that would be considered.
It's fair. I would say, though, if we plan for it, it's easier for, at least I'll speak for myself, it's easier for me to make more time going forward if I plan for it now than wait to the end of August and find we need more time. My calendar might not allow for it. So
Right.
I just want to get a sense of, is that something that we're going to?
Right. So to that point, just maybe I wasn't very clear, and maybe I'm not understanding you, but we would decide before the end of August, but we would decide before our standard meetings we have set up for the next, 2 meeting times, the 22nd and the 29th. So maybe we can reassess at our next meeting. Is that reasonable? And see if we need any time beyond those proposed dates we already have, or the ones we've agreed upon. Does that, Timothy, kind of meet
Sure.
you?
The next meeting will be a good point.
Yes, that kind of be midpoint, right? Well, more than that. We've had 3 meetings. It'll be our 3rd meeting. Thank you. Great
Thank you.
question.
Yeah.
And any other questions from the fabulous team? And so what we're going to do now is talk a little bit, and Dr. Williams is going to do that in terms of the overview of the process and, well, the summary of some of the key barriers and some of the things we discussed at our last meeting and kind of our next steps with that for our activities today. You're on.
All right. Thank you, Dr. Talbot. Ready to jump right in there, guys. So based on our minutes from our last meeting, I looked at the main barriers that we discussed, and it seems like there are about 6 of them. So mainly we talked about transportation needs or lack thereof, proximity of the healthcare to certain parts of Lexington, mental health care services and stigma, workforce diversity, health equity data as it relates to social determinants of health, and healthcare provider cultural competence. So it seemed that most of what we discussed over the last week came within those 6 topics. Does that seem fair, guys, based on your remembrance of our meeting last week? Is it anything we need to add?
And did you all get an opportunity to look at the shared document on the Google? Okay, excellent. I'm seeing some people nod.
Fantastic.
Some, okay.
I did have some more stuff that I would like to add to what we may want to discuss.
Sure. Regarding barriers, Mr. Overstreet?
Yes, regarding barriers.
Sure,
yes,
jump right in.
So I hit the streets last week just to see what I could find out from other people. And other than those transportation and proximity barriers that I had already mentioned from people in the West End, I went to a senior living facility, and one of the barriers that they identified from there was the information of available programming that is out there for them. They say that people come and give them some of this information, but they don't really understand it, and they're not really it's not the same language that's being spoken. So there's a certain disconnect that happens when people come into these senior living facilities and give out information, but the information is not well, not received, but taken in.
That's a very good point. And you know what, Mr. Overstreet, that reminds me of what we discussed last week when we talked about someone mentioned the importance of having a community health worker or some liaison available in the community to help people understand resources and link them to it. So that's a great point. I'm glad you brought it up.
And also another barrier I think we failed to recognize was the difficulties that you all as people of color, as healthcare professionals face in coming through the ranks and then actually working in the industry, because you guys are part of the community as well. And if we're looking to get more people of color in those positions, then we have to look at the barriers that they face before they can get in those positions.
Yes.
So those are the 2 I have. Thank you.
Great points. Thank you.
I was going to add something too, if I could. You know, I put on our Google Docs 3 articles that I went through this week, and there were some really interesting things that popped out to me. And one of them was that we have a 2-tiered health care system, and I think that comes back to, you know, the private insurance, and I think I think that exists, and because of that you have this inequity. Also, I think that the research area in terms of Black leadership is not there, and I think that we need to look at that. And I was also looking at the Black population is 13%, yet only 4% are doctors. And so right out of the starting gate. So I think we need to look at some root things that are going on because that ratio is, and maybe there's something we can do with our med schools and universities, and I'm not sure what that is, but those just kind of popped out at me. So I thought I'd share.
Right. Great point. Thank you.
Kathy, this is Brandy. I have a quick question. Can you tell me a little more what you mean by research? Wait, you're unmuted or unmuted. I don't think we can hear you. There we go.
I think what it was referring to, and I don't have the articles in front of me, it's just medical research, because folks have different types of, as a result of situations, I believe, that we just need to take a deeper dive into that. But those articles are on the Google, and again, I'd recommend reading them because I thought they really brought out a lot of good points that I hadn't thought about. I mean, I'm not there. The other one thing, and Brandy, I think you said this last week about the commissions.
Kathy, you would have been the one to post that.
The only reason I said that is because, and this isn't a downer. It's just it's been 21 commissions over the last 150 years. And I just thought that was interesting to note.
It was very interesting.
Okay, just wanted to
It was.
Thank you.
Well, as a junior faculty member who focuses on African American research, I think it is a big barrier for me. I mean, it's more challenging for me to get tenure because of the type of research that I do. And I know Dr. Williams can talk about this too. And it's getting back to the point of what Mr. Overstreet said about the barriers that we face. I mean, I have gotten very little support in my environment where I'm supported for doing the type of research that I do or the type of outreach, and recognizing that I'm not going to do research on people. I'm going to do it with them. And that takes time to build those relationships. So I know it's a challenge from the Black faculty members that I know who are junior face, but it's really getting to a culture shift.
Valid points.
One thing I was going to add, just to share a little bit about myself, I do have a strong passion for health disparities in the community. There's a PowerPoint presentation that I have. It's called "Keep the Receipt on Your Health," and it basically goes by a play-by-play of interaction from what a patient does coming in, from check-in with your insurance, having a valid insurance, and empowering the patient to ask the right questions and to educate themselves before they get in there. Why is that important? As a physician, I have 15 minutes for an acute checkup, 30 minutes for a complete physical. One of the more powerful presence that a patient will have when they come into the room is have a pencil and pad. Some of my colleagues get intimidated by that, but I think one of the things that happens with empowerment with African American disparities is we live in the internet age, right? And so simply Googling the top health concerns of Black men, top concerns of Black women, and writing that down on an agenda when you come into the office. So keeping the receipt on your health is empowering the patient to become more educated about their conditions, to take control of the visit, and to make sure that your concerns are addressed before you leave. There's something I always say: if you come in this office, the same that you came in, you wasted my time and you've wasted a copay. And so there's kind of a mantra of getting patients to be educated about their position, their condition, but at the same time, one of the more important things about the patient-physician relationship is trust.
Yes.
And so you have to build that. And I also emphasize it's important to have somebody on the other side that looks like you, that you can confide in that, because there's a lot of different psychosocial entities that are culturally ingrained within us that we don't feel comfortable maybe sharing with other races. But at the same time, when you come into that visit, you keep the receipt on your health. You have your own file cabinet at home? When was your last colonoscopy? When was your last lipid profile? What was your PSA? You've never heard those terms? Why don't you understand those terms? And so, you know, I can share that when I put it on PowerPoint, but that was one thing that I had taken in as far as keep the receipt on your health. One of the barriers parts is finding out more about who you are, what your condition is, who you can trust as far as taking care of you. But that trust is a relationship.
Yes.
And so,
Exactly.
so important.
Absolutely.
So I just wanted to share that with you.
Nice.
We're coming from external, but actually one of the barriers that we have to get over is our internal and taking control over that.
Yes, absolutely. Thank you guys for those remarks. And that's an excellent segue into where I wanted to focus our conversation today. I want to encourage all of you to go to the documents that Andrea shared with us. Pay particular attention, if you would, to a document that she posted regarding a program called Policy Link, and some work that they've, a framework that they use to address health inequities within a community. When I listen to you all talk, and we go back to what we discussed last week, much of what we're discussing, it falls within the framework of social determinants of health. And what that means is that our health is really based on factors of where we live, where we work, where we play, our economic situations. So even what we're talking about as it relates to feeling empowered to speak to our healthcare worker, or having a healthcare worker that reflects our images, all of those opportunities to have those experiences can lead, are directly related to social determinants of health. Being able to attend school, if you're a person of color, being able to access food if you're living in a community that lacks those access to those factors. So what I'd like for us to do is think about, in a broader framework, how we can address social determinants of health that affect health inequities. Vicki brought up last week having access to data. And one of the files that's on our Google Drive is strategies or recommendations for addressing those topics that we discussed. So if we think regarding the scope of what the mayor can do, what's within her scope of influence that she can make changes, and who the city can partner with to help her make these changes, I think that might help us move further in our strategies to use. So I want you all to think, based on what we've discussed thus far, who should be at the table, who those partnerships should be with, and how we can move forward with these strategies.
Well, I would definitely say, which she has been partnering with the Lexington Fayette County Health Department. I mean, she has been doing that and to continue to do so. And one specific strategy that I posted on the Google Doc was, as we go, and I say we as in the health department, as we go into our phase of planning the next community health assessment, it would be nice to have someone from the mayor's office dedicated to studying the African-American community. I mean, we had 1,300 participants in the last survey 5 years ago, and about 30% were African-American, so it was a good representation. Right. However, I would like to see something that is very specific, because some of the problems that were identified as a community whole may not be the same if you just look at the African-American community. And so I just think that that's an easy strategy to get some local real-time data.
I mean, is when we look at the data, is it categorized, I'm assuming, by when we have to look at disease process? I mean, cardiovascular, diabetes, I mean, how is it categorized? I mean, is it?
So the community health assessment is more based off of the social determinants of health.
Okay.
And yes, looking at, for example, I just happen to have it here, looking at what does the community perceive as the greatest health and well-being problems in Lexington, what are the community identify as some of the prominent issues, and what the community identifies as some of the risky behaviors. And then there's other questions on there that are more geared towards the social determinants of health as well. So it's not Dr. Gilliam, who's the greatest doctor ever. It's not necessarily geared towards processes, but what the community perceives as issues and what their barriers to achieving health is.
Well, the reason why I just asked that is because what the survey, what the perception is, obviously we want to make sure there's a standard of what their concerns are that matches up with hitting key things that are important about the community. So in other words, if there's, concerns of financial or transportation or something specific, air quality, that can be linked to, asthma, that could be linked to mental health. So in other words, is there a way of taking a standard of disease process, both for men and women, and healthcare disparities, African-American, Indian, Hispanic, and then also correlating that with the information is coming in and categorizing it? Because if the survey is coming in with all this broad information, what the concerns are, and we don't categorize it, we might miss a disparity. And so I was just trying to see how that data is being, correlated, towards a litmus test, so to speak.
Yes.
Sure, absolutely. And
Yeah.
for more specific questions, I would have to hook you up with our EPI team.
Okay.
Vivian might have some insight on that. You're muted, Vivian.
Viv, you're muted.
Muted.
I worked on that assessment. I can answer it if you'd like me to.
Yes.
Okay. So 5 years ago, when that community health assessment was done, Mark Johnson and I specifically did an oversampling of the African American and Latino Latinx population in Lexington to get that number to where it was, because it was abysmal before that. So a lot of the issues that came out of that were relevant to the African American community were addressed for the first time in the sub work groups that came out of that assessment, meaning employment, economic development, job opportunities, community safety. And one of the pressing work groups out of that, Jay, that had to deal with diabetes, obesity, and physical inactivity in our state. And Lexington's numbers were high with that. So that was one of the chronic disease areas that we focused on. Okay. And there were several others, but that one had the greatest numbers. So that was how we connected some of the responses for social determinants to address those obesity and diabetes rates in our state as it relates to communities of color. So that's how that was done. So it's going to be coming around again, as Casey said. So I do think it's important that we have someone, a liaison from the mayor's office, to see what rises to the top and what some of those communities of color are saying again, and some things that weren't addressed the last 5 years that are still present today, because some of them still are.
So Vicki, could you speak more about the subgroups? What are the status of those work groups now?
So before COVID, everything before COVID, those groups were meeting monthly to kind of assess where we were in moving that community health improvement plan, because out of that community health assessment came the community health improvement plan that the Lexington Fayette County Health Department kind of drove, right? And all of those subcommittees put forth initiatives as far as economic development, jobs, community safety, violence, and gun safety came up, and then working on physical obesity and physical inactivity as it relates to what we could do as a community to get people more active, to drive down some of those numbers. So those groups were still meeting. They were still putting forth activities. So, but as soon as COVID hit, there's been nothing.
Yes.
I'd say since, maybe Casey can quantify, but I'd say since November or December of last year, giving Christmas in there, we haven't met at all the different.
And that's accurate, Ms. Vivian. It's been about the end of last year, and I can send this document out to everybody if that would be helpful to see, because it has the work groups listed in it as well.
Yeah, Casey, if you could send it to Andrea, then
Okay.
she can put it on the Google Drive for all of us.
I think it's already on the Google Drive.
Oh, it is? I didn't see it today.
Yeah, I think it's on there already, kind of, and I can share. This is kind of
There you go. Yes.
Oh, yeah, fantastic.
Oh.
No, I don't see it on the drive though, Andrea, but thanks for
I
sharing.
didn't see it on the drive. Yeah,
Okay, let's see.
These are, this is just the screen. Let's see. No, this is the whole thing. Okay.
Yes.
So this is the whole thing. This is what the cover looks like. And I pulled this right from the drive. So it.
Oh, yes, yes.
But here are the categories, and it has the one particular area, social determinants of health are explicitly discussed here on page 7. So health, there you go. So we heard a little bit of that in our first meeting, and then on to the details as Vivian was explaining. And then Dr. Gilliam asked kind of, the overlap of issues. These are some prominent issues there in the middle that popped out, which overlap with many of the other subcommittees.
Okay, that's excellent.
Yeah, it's just a really great document.
Would you mind to scroll back up? Would you mind to scroll back up to the social determinants of health for a minute?
Absolutely.
Please? It looks like one's missing.
Let's see here. Which one's missing? This. There we go.
Yeah, food is missing.
Where's food?
It's on the left under economic stability and under neighborhood and physical environment.
So I've seen other charts that actually show 6 social determinants of health.
Yeah.
Food and food access being an independent category. That's why I was curious.
Yeah, it depends on the
I've got another one
that's
actually got 6 categories.
Yeah, it depends on the reference.
Yeah, and also remember that this was from 5 years ago as well. So you may have
right, exactly.
Charts may have
Some do
changed a
6,
little.
some still do 5.
So I'm interested more in the work group. Who's on those work groups?
Various community. If you scroll down, Andrea, there is actually a list of all the community partners. Of course, it's changed because this document isn't living. So that it was published 5 years ago, and so it's changed greatly since then. But I mean, so membership has come and gone, but that's given you a good basis there.
So where does the information live that talks about their work and the progress and things accomplished?
It does. I can get you those. I can get you those updates. We receive those as a board on a quarterly basis, and so I can provide those with you because it's public.
That would be a great also catalyst for us, right? And so see what actions have already are in flight and maybe what should be capitalized off of or segues into some of the actions that we do here. I mean, we don't have to reinvent the wheel, right? Especially
right.
The new
Absolutely.
And so the reason why this really came to mind is I was just talking to our staff person who's in charge of this the other day, and I was like, oh, it's about that time to come. And then I thought, it would really be great if we had a dedicated sub team or subcommittee or something, particularly doing data assessment for our African American community. As Ms. Vivian said, thank you so much for all the efforts you did to get it up to 30%. But that would not have existed though, right? Had you all not pushed it. So one dedicated to just that community would be great.
Yes. The community partners, I'm interested in if they had defined roles for their partnership.
I can get you the complete list of each subcommittee, like the different people and their roles on there.
So I think one of the questions earlier on was what partners should be involved and what could the mayor do or what could we recommend to the mayor? I think in terms of looking at some of the social determinants, whether it's economic stability, food, education, even the community and social context bucket. I think it's critical to have nonprofits as part of that conversation because they cut across all of these and probably more and could be sort of integral partners in making that happen. And specifically, I think if we want to be very intentional, we should recommend to the mayor considering doing some place-based investments or place-based sort of pilots of programs in certain communities. And that would help mitigate some of the challenges around transportation, around sort of relationship and access. I mean, having something in someone's community that they feel is a community resource, both for both Black and Latino and other communities of color, I think could go a long way into making sure that these resources are utilized and accessible and feels part of their community.
And I'll add, I'm sure that the mayor already has programs with them, but strengthening the relationship with Lexington Housing Authority and continuing that, especially with some of the recommendations that Mr. Johnson gave with place-based outreach. There are a lot of great opportunities that creative strategies that we could implement in those communities to address a lot of these determinants of health.
Right. Can you hear me? This is Mark.
Mm-hmm.
Yes.
Yes.
Okay. I just wanted to make sure that when we're
Yep, we
talking,
can hear you.
okay, thank you. I just wanted to make sure that when we're talking about all this, that we make sure that we include the trans community of color and also the LGBTQ community. And neither that this doesn't have an effect, but HIV and AIDS is also of utmost concern to our community, and we don't want to talk about that. So when we're talking about the community at large, I just want to make sure that our committee is making sure that we include the other populations that are within our community.
Thank you.
Before Corona changed the entire world, the mayor was forming a committee, enlarging One Lexington, which is being run by Laura Hatfield from her office, who was absolutely amazing. And what it was doing was trying to bring together a bunch of community organizations for programs like this. So I think one of the things we can suggest is that One Lexington pays special attention to some of the issues, some of the pillars that build up the health problem so that they can help address it. Because what they were trying to do was bring together the vast array of groups we have helping in the community who are overlapping or could be working together. So this could be one more thing that they can try and push.
I agree.
I agree. And Laura's she is really superb.
Awesome.
So
I don't think we need to take a vote on that.
I believe you're right.
Can I share a quick perspective?
Absolutely.
Would you mind to bring back up that social determinants of health chart that we had shared a minute ago? And I'm just going to pick on one of these as an example. So under healthcare system, access to healthcare. So when I think about access to healthcare, and I ask myself, what are the potential barriers for an individual, regardless of who that individual might be, a person of color, Latino community, African-American community, gay, lesbian, whatever the case may be. If access to healthcare is determined by whether or not someone has insurance, just using that as an illustrative example, and the primary care physicians that are available to an individual that has access to insurance is a list that's defined by that insurance company, compared to someone who doesn't have insurance, who doesn't have the same kind of list. How do we alter the system that's in place to provide information to an individual who's seeking healthcare? And it kind of goes back to what Stephen said last week. It's about whether or not you trust a primary care physician, whether or not you even have access to a primary care physician. And if you don't, your default may be to go to the emergency room or to go to an urgent care. And you're going to get a different kind of urgent care or a different kind of care in one environment versus the other. And so when I compare and contrast that illustrative example to what I see every day in hunger relief. When someone needs food, it's about helping that individual find access to food, whether it be food stamps, whether it be a food pantry, whether it be a grocery store, and the list goes on and on. So could or should some of our work be, we know that there is a barrier, if we believe this to be true, we know there is a barrier around access to healthcare that might be limited by whether or not someone has insurance. How do we change the system to provide a list of healthcare professionals that are available to the community who may not otherwise be able to see that list? So I'm kind of going with how do we take these various social determinants of health and provide access information to those who may not have it readily available because of their circumstances to make it more readily available? Now, that's a very tactical, very action-oriented kind of thought, but it seems to me that if we're trying to break down injustices in systems, we've got to talk about what some of those injustices are, what creates some of those injustices, and how do we change them? And if we think the ability to have or not have insurance is an injustice, how do we circumvent that injustice?
And before we answer that, I just want to say to Andrea, Andrea, would you please let Dr. Williams back into the meeting? She got disconnected. Sorry.
Yes, I do not have access to it, but I'll get someone to do that.
Okay. And because we can't chat, I couldn't send you a note. So
okay.
Thank you.
Mm-hmm.
And sorry, Vivian.
So if I could just respond to Mr. Halligan's comment. So the social determinants of health subcommittee that was part of that community health assessment, and this may partially address your concern, came up with a kind of a resource directory, and Casey, I'm not sure if that's still around, of providers and all those social services and entities within Fayette County around issues of homelessness, things for our veterans, folks that were on limited income. So there was a kind of a resource directory, a depository where we could go, where people could find that information. It was in one place. It was a one-stop shop. I'm not sure, Casey, whether that ever got, and Katrina Howard would know, I'm not sure if that ever got in a publishable form or not, but we talked about having that kind of information in one place. So I do agree with you, it would be helpful. And we also talked on a project Mark Johnson and I were working on having a list of physicians and medical care providers within Lexington that where people could trust, people felt comfortable going to, people that accepted certain forms of insurance, that worked around certain issues. And Jay may speak to this too. People feel comfortable going to providers that look like themselves, that have a particular interest in a certain area. So we were at one time trying to put together a physician directory. And I don't know if Dr. Gilliam remembers Dr. Gonzalez when she was at UK, but she wanted to do the same thing with the Bluegrass Medical Society, I think it was, that she was over at one time. So there have been opportunities for us to do that. Maybe that's something we want to have something that comes out of this work group, to have a document like that, a place that lists all those things you spoke to. I don't know.
So maybe just to build on it a little bit. I'm sorry. Maybe just to build on it a little bit. I've been sitting in on a group of conference calls on reentry. So think about individuals that have been incarcerated, and because of COVID-19, a number of individuals have been released. How do you help individuals who have been incarcerated know all of the different things that are available to them to help them with reentry? And it was eye-opening to me to realize that someone who found themselves in those circumstances might have to make 15 or 20 calls to get basic services because they're not all in one place. And if that's a systemic failure on assisting an individual that's in a circumstance, how do we circumvent that systemic failure to make it easier for someone to access the things that they need access to? So it's great that the list exists. We need to get it published, and we need to make it easy to use so that people can actually access it and use it.
Right. And one thing I just want to piggyback on what Vivian had mentioned, even within those lists, I always say, you know, and I tell my medical students and residents this, I don't care how much you know until I know how much you care. And I think the key thing is going back to empowerment, and you mentioned about the reentry, because even though when it's said and done, you have a list of names of providers that are there, that you go through the process and get to that provider, and you may not have an established relationship. So you need to know what your worth is as a patient, because you can go in there 15 minutes. I get 15 minutes for a follow-up acute care. And once I go through, that's it. I'm on to my next patient. And you're left with either knowing more about your issues or not, or you just take your medicine and just, why? Because Dr. So-and-so said so, or I'm not really feeling Dr. So-and-so, but he's all that's here in this environment. So that's what we have to go with. So I think one of the things is, like you said, having that list, but I'm really big at empowering patients to know about their condition, take control of the visit. And if you find a provider that's intimidated, I'm not intimidated by articles, Google search, I'm not. It's a way of getting patients to have them research their issues, but also facilitate dialogue. If a patient doesn't know their worth in that clinic office, that's one of the disparities that happens behind closed doors that nobody talks about. And so with that list, finding warm providers, maybe I can say that, in the community that are familiar. Taking as example, I have some colleagues who are nervous about LGBTQ. They're not comfortable with it. You have to be comfortable with it. You have to be comfortable with addressing those issues. And so, if I may add, in that list, we need some warm providers by either feedback from other people who have been to these providers, individuals who won't have a problem treating you or your family member. But I think that is so important to have a list of those providers that are warm and community conscious, if you will. And I know a lot of my colleagues aren't. They're, and that's fine. They're excellent physicians, but when it comes to psychosocial issues or just some other things, they're not comfortable with it. And that's good, and that's not good. I mean, that's something you have to overcome that. But I just think one of the barriers inside a clinical setting is a relationship. And it's so important to have that relationship. And if I don't trust you, I'm not going to follow your medicine. I don't care what my disease state is. I don't know what my worth is. So I think that's so important.
I agree with Dr. J.
I would
add. I think part of the problem is that oftentimes I've been accompanied several seniors to the physician when I worked at one of the local facilities, and the disrespect that's there. They would call somebody else Mr. and Ms., but when it came to a person of color, it was their first name. And then the way they told them to get over here, get over there, sit over there, and the general disrespect, you couldn't get past that. And so then I had to chime in. So imagine all the individuals that go to physicians and providers that do not have somebody with them to help them speak up.
Absolutely. So what we are talking now, we're back to cultural competency and being able to work with individuals who are unlike ourselves, are similar to ourselves. Think about that within the context.
I got to go, so I apologize. I got to go get my kids. So I thank you all.
Thank you.
So
thank you.
The next meeting. So thank you.
Good to see you,
Bye.
So we will think about that within the context of the mayor's office and city leadership and what she can influence. What comes to mind?
I think somebody put it
I
on
just wanted
there.
to,
Okay.
Dr. Boateng, I'll give you one.
Yeah,
I just want to mention one thing before, if Dr. Boateng will let me. I see you wanting to talk. So I just want to say one thing is you hit on something, Dr. Williams, that I really think is going to be important here, is the community health worker model. We only have 2 certified community health workers in Lexington that I'm aware of, meaning they've got a certificate saying they've been trained to do that. That would be worth investing in, especially in our communities of color. And that kind of connects those services too, Mr. Mike, about making sure that everybody knows what's available, whether that's in the form of a directory or whether there are people sitting in the community that know how to connect the dots. So I just think that's so important of having those lay health community folks. So.
Absolutely.
All right, Dr. Botang, go.
Okay, I'll make this super quick. So we talked about, health disparities and how individuals, they go to certain places. So if I go to the ER, then I'm supposed to expect a completely different experience than if I go to my medical provider, yet they're both doctors, they've taken the same Hippocratic oath. Same thing for my profession. So it's like, there's assumptions made. So of course it comes back to cultural competence, but I think, as I've been thinking about this over the last couple of weeks, the issue is jurisdiction. So most of the time with mental health profession, that's state regulated. So the mayor would not, although I'm sure she can ask nicely, but there's really no leverage to say, well, yes, we do need culturally competent CEUs. We do need culturally competent providers, because let's face it, a lot of us are saying, well, African-Americans enjoy seeing other African-American providers. The numbers just aren't there. So does that mean that non-African-American providers are just off the hook and can do and say whatever they want? I think that's ludicrous. So we should have an expectation for all providers, all licensed individuals, but unfortunately, again, the jurisdiction is not as simple as one would wish.
But can we talk in academia a lot about the environment, but as the mayor has influence over the environment of Lexington. So if the environment is inclusive, then over time that will produce more providers of colors, more access to resources to support what we're after. At the end of the day, what we're more concerned with is having providers who are culturally competent with all of the communities that are available in Fayette County, not just a certain population. So when I think about the influence of the mayor, we have Leadership Lexington. Is there a way with programs that are supported by the city, if we can recommend cultural competency training within those programs? So not just learning about Lexington and how we can influence change in Lexington, but how we can be a better community, a more inclusive community. And a lot of times that comes with understanding health inequities and racial inequities. And I'm not sure that that is a part of any of the training programs that we have here. Can anyone speak on that?
Dr. Williams, I can't speak necessarily on those programs, but I will say as part of the commission are state representatives. So you have Reggie Thomas and George Brown that are part of the commission as well. They're sitting on other committees, and I think they're part of the full body. So don't feel limited to Fayette County boundaries, Dr. Botang. Feel free to make recommendations at state level, because we do have those representatives willing to speak up on behalf of whatever recommendations come forward.
Thank you so much, Andrea, for that insight.
Yes, because Dr. Williams and I had talked about that, and we were really talking about the scope and the sphere of influence of the mayor, which was going to be very important here in terms of what we're able to do and what we recommend. So that's just good to know that it can go beyond the boundaries of Lexington by some of those individuals that are connected with the representatives. So that's great.
So speaking to the point, I'm sorry, Dr. Calvert.
No, go ahead.
So speaking back to the point of the resource guide, or resource directory that I heard folks speaking of, I want to also offer up that there's another sort of existing resource guide of sorts. It's called 211, which is a 24-hour day, 7 days a week service that really gets people to the provider that handles all myriad of social determinants of health. So, the things we talked about, education, economic stability, what have you, there's a 24-hour helpline. So no, it doesn't get to what Dr. Gilliam talked about, the sort of warm and the cultural competencies, perhaps, but it is a resource, whether you are a individual who are reentering the community, or if you are homeless, or if you're experiencing homelessness, or if you're a veteran, there is a resource that you could tap into both via free phone, or if you have a cell phone that you can go to online. A possible partnership with the mayor's office could be, how do we make it even more comprehensive? It's pretty comprehensive, but we don't have necessarily health providers like doctors. We have mostly sort of social service providers.
Social services.
Maybe that's something that we could partner on to figure out how do we help make it even more robust than it already is and fill in those gaps.
Yes.
Great discussion.
And before I drop my call, from looking at the list of partnerships that the subcommittee from the health department has already developed, what I want you guys to consider for homework is looking at that list and see who's missing. You know, who's not represented on that list already that could provide a great partnership for us.
And I think to Timothy's point is also looking at those nonprofits as well because of
yes,
the funding piece and
yes.
some resources. So I think that is fabulous.
Yes.
You know,
If I could comment on, oh, go ahead, Kathy.
I was just going to say, with the Health and Human Services, I'd like to see a profile of who are using that. You know what I'm saying? Is it just appropriate? I mean, are there more of folks that are, I guess they are on the lower end, but I'd like to look at some of those profiles. I don't know, Timothy, can we do that on the on that nowadays? I don't remember. From
On 211 to figure out who's calling, what kind of calls.
Yeah, like
yes, for a given zip code, I can tell you what kinds of calls are being received, whether it's of a mental health variety, if it's of whatever. Yes, those are reports that we can pull up.
Ethnicity and diversity.
So it doesn't get into that. No, that kind of information is not collected currently. Okay. But maybe that's something that we can check to see if we can integrate that.
All right, thank you so much.
Fantastic. Right. Is that something you can share with Andrea to put on the Google Drive for us?
Sure.
Thank you.
Sure.
Thank you. So you all, we have 4 minutes left.
Dr. Williams, can I say something really quick?
Absolutely.
I had put under workforce diversity, one of the barriers, and this is something I've experienced while I've been at UK and I've experienced it at other places, where when we send faculty members out to recruit students and minoritized students, I've heard faculty members come back and say, well, they weren't college material. And that's really unfortunate because something else that we hear are there not enough qualified applicants when we know there are. So I think the mayor's office is in a great place to bring together large, predominantly white institutions like the University of Kentucky and build partnerships and sustainable pipelines with our elementary schools, middle schools, and high schools that serve majority Black and Hispanic students.
Yes. Yeah. That's a great point, Dr. White.
Rabbi.
If I could just comment on 2 things that.
Go ahead.
The first is, first of all, Brandy's always right. But something she was saying to double down on is, I don't know what the percentage is, but UK is a large percentage of healthcare in this city. And while the mayor does not have authority over state institutions and private institutions, et cetera, Lexington, Fayette, Urban County has a tremendous relationship with UK on a plethora of things. And we have an ability to influence UK healthcare far more than almost anything else. And being as, I think, less than 10% of healthcare employees are people of color, and I think more than I think 40% was what it said of patients were people of color. That is a great place to start. But I wanted to just touch on one more thing. When we talk about cultural understanding, that's only the first step, because what we need, and we discussed at the last meeting too, is trust. My personal mentor, one of the foremost leaders of world Judaism, the Lubavitcher Rabbi Menachem Mendel Schneerson, would often be approached by many Jews throughout the community and asked questions about health for a blessing, for advice. And one of the most common things he would advise is speak to a doctor who's a friend. And that just doesn't exist for many portions of our community. So even if the person does understand my community, even if the person is of the same race that I am or ethnicity, et cetera, if there's no trust in that relationship, it takes away a great deal. And so that I don't think we should just try to promote, and we were saying among healthcare workers in the city, among the idea of, oh, be aware of what this community's issues are, but be willing to to go to a place where they're able to build trust in you, invest in what their values are, because trust is really what we need to build here.
Right. Absolutely. That is an excellent point.
I agree. So we've had a lot of good things, and Dr. Williams made a great point. Because we're at 4:59. We really need to look at the information that I think that Timothy was talking about, and if that's going to be placed on our share, that would be a great starting point. Partnerships, excellent idea. Rabbi Lipkin, I work at UK Healthcare, so I couldn't agree with you more. That was one of the things that attracted me to this group, because we have opportunity and the time is now. So I think that we definitely have to leverage these things. The other things that I heard was about the navigation, the repository for information, MD patient concordance. And I think that we're kind of moving these are very synergistic concepts that we could work on. And I think, Vivian, it would be great, because you mentioned the healthcare worker or community, health worker. Is there any way that we could be provided with maybe a job description or some example of what these individuals do that we can consider before our next meeting to discuss, as well as Casey, some of the information from the subgroups and what they've done and what might still be in the queue, so that we could look at those things also in terms of how we prepare for our next meeting and start trying to solidify some action steps we really want to
Yes.
So, Dr. Williams.
Can I?
And there was one
Dr.
more.
Talbert.
Yes.
Can I submit a data tool through the Google that I think that looks at county profiles that really give a better snapshot of Lexington and the data that's kind of
absolutely.
So I'd like to put that in there if I could, and then add something to Dr. Williams, your bucket that you said there were 6 areas. I think we really missed one that I would hope included, maybe if everyone agrees, is the communication piece. The health literacy piece is critical, and how you communicate with communities, because we recognize that the message, that one blanket message going out across the state, wasn't resonating with Black and brown communities and other folks. So I think that's still something that the mayor could work on, because even her press conferences, our governors, were missing a large group of folks. So
absolutely. Thank you, Vivian. That is so important. Another homework assignment is to, Andrea posted a document on the Google Drive called the Policy Link document. It has some great information on previous programs along the lines of what we're trying to accomplish. So if you have an opportunity, please review that prior to our next meeting. Yeah. The strategies document is a live document. So over the week, as ideas come to you, if you could add those to that single document. And the title is Health Equity Subcommittee Strategies.
Okay. You all need something from me when I was not on the meeting, and I thought I heard my name early.
Someone had asked the question, Andrea, about the town hall, as well as, and I think it was Kathy perhaps, but the town hall meeting and the meeting with the urban county government, would those be available to allow other people to view real time or later, I guess?
Yes, I believe that it'll be the same format, council member. I think it'll be Zoom like this, but then viewable on YouTube as well, from what I know. But I think tomorrow they'll be working out the details of that.
Thank you, Andrea.
You're welcome.
You all, this has been a fabulous meeting. I'm very pleased with
always,
and I hope Dr. White is as well. And even though I keep picking on Dr. White, I need to stop doing that. And it's all out of love, trust me. Yes. So fabulous meeting. We'll see you all back a week from today, basically. I think 3 to 4. I know 3 to 4. And you all have really been great. I think we've made a great deal of progress and some really strong discussion today.
Right.
Dr. Williams.
Send those resources to Andrew.
Absolutely. Andrea is a great support.
Yes. Thank you, Andrea.
Thank
My
you.
pleasure. Thank you.
All right, you guys, don't forget your homework.
Yes.
Thank you.
All right, bye-bye.
Thanks, everybody.
Take
Be
care.
safe, be healthy.
Yes.
Yes.
Get better.